and and on the national homeland of the Red River Métis. Um, some of the work that you'll be hearing about today is a project that is very closely tied with the effects of colonialism, residential schools, and we take it very seriously to ensure that we are reflecting on those effects and making changes that will improve the lives of Indigenous populations moving forward. So, who am I? Maxa gave a quick introduction. I'm the Associate Director for Equity, Engagement, and Impact at the Manitoba Centre for Health Policy. And I'm also the Inclusion, Diversity, Equity, and Accessibility Team Lead through the Health Data Research Network Canada. Those are my professional titles. I acknowledge that I'm also a settler colonial woman. I'm a sister, daughter, and aunt. I'm visually impaired, and that's affected my journey through both education, health, and other systems, and really has provided a lens from which to look at some of these issues. I love learning across disciplines. I come from a very cross-disciplinary background and love to think about how we can speak to each other. A lot of times we're using the same language or, you know, want to forward the same causes, but might be using different language. And I love kind of being at the intersection of those conversations. And I would also say I'm a human rights advocate, want to ensure that we are treating all humans as they should be and really thinking about this in the context of data. So, as I said, I work at the Manitoba Centre for Health Policy, which is a research unit in the College of Community and Global Health at the University of Manitoba. We have about 65 staff and 12 faculty members. We're located tucked away on the fourth floor of the Brody Center. MCHP holds the Manitoba Population Research Data Repository, which includes de-identified data from many different domains, including healthcare, social, education, justice, and other registries. And we can link those data over time across generations within families and so on, and have that kind of high level look at population outcomes. And I will say that MCHP is unique in terms of having so much social data and having that ability to look at social determinants of health alongside some other health outcomes as well. So I work in the area of IDEA, so inclusion, diversity, equity, and accessibility. You will hear many different versions of IDEA. Oftentimes it's called equity, diversity, inclusion. In some other contexts, it's EDIA, so adding the accessibility at the end. In other contexts, it's EDIA-IR, so including Indigenous reconciliation. In the context that I work in, we went with IDEA both in terms of trying to get across the sense that we are working to practice IDEA within a realm of research and data, whereas EDI is often thought of in terms of human resources and other kind of human resource management ideas. So just trying to make that slight differentiation. Lots of different organizations use different things. I think we're all talking towards the same goal. Again, here's one of those cases where we might use different words to talk about the same end goal. So oftentimes when I say I work with IDEA, people will say, "Oh, well, you must do public engagement." And I say, yes. And so I see public engagement as one tool to practice IDEA. And that's really kind of thinking about these systemic barriers and incorporating social solutions to those systemic barriers. So engaging people, getting input, whatever that might be along the research cycle. I will say, though, that there is another component that I really implore researchers to use when thinking about how they can apply IDEA, and that is around data equity. And for those unfamiliar with data equity, I will just put up a short definition here. So data equity is the consideration through an equity lens of the ways in which data is collected, analyzed, interpreted, and distributed. Data equity pushes us to consider the ways that data can reinforce stereotypes, exacerbate problems like racial bias, or otherwise undermine social justice. From my understanding, equity is about both understanding where the data comes from, how it is prepared for us to use, and then used and distributed afterwards so that we can fully encapsulate the different ways that bias can work itself in throughout that process. A lot of times, researchers will look at data as some sort of objective or neutral object of truth. And data equity really pushes us to say that data comes from somewhere, whether it's colonial, racist, patriarchal systems, and how do we reflect that within the analysis and distribution that eventually comes from that data? And so I see these as very complementary, whereas public engagement sees systemic barriers and finds social solutions. Data equity sees systemic barriers and kind of makes us look at technical solutions. Both of them require some facets of engaging with the public. Obviously, public engagement is fully focused on that. Data equity includes that, but it's one component rather than the whole picture here. And so we'll see this is very complementary. Um, for those kind of more enmeshed in the public engagement discussions, you'll have seen various diagrams about where and how you can engage the public within your research, and that's on the left side, hand side here. And then with data equity, this is reflecting the different pieces in the data life cycle. So around collection, data stewardship, processing and tools, methods, analysis and interpretation, and then mobilization. And so there are various different ways that you can think about embedding equity, both from a public engagement and a data equity perspective. And so I'm going to talk about this in the perspective of a project that we worked on over the last 5 years. This project was funded in 2020 to describe the incidence rate of first-time healthcare system contacts documenting methamphetamine use. It was around looking at geographic distribution of Manitobans who had contact with the healthcare system, who related to their methamphetamine use. And it was looking at demographic characteristics of Manitobans who had contact with the healthcare systems related to their methamphetamine use. This project came from a deliverable that was uh, requested by the Manitoba government, which showed the rise of meth use in Manitoba from 2013 to 2018. And I think the study that preceded the one I'm going to talk about was really instrumental in showing just the depth of this issue and helping to dispel some of the um, stigma around methamphetamine use in Manitoba, whereas I think a lot of people saw methamphetamine use as a very, core inner city issue, and the study that was conducted showed the widespread geographical use, especially relating to Winnipeg Fire and Paramedic Service response, and was a catalyst to wanting to learn more about methamphetamine use and contact with the healthcare system. This is another statistic that came out of the first study. So, about 20% of all other Manitobans struggle with mental illness, whereas 70% of Manitobans who have used meth had a pre-existing mental illness. And so, Health Canada funded a project through the Substance Use and Addictions Program, which the aim was to use MCHP data to build knowledge to better support individuals and to reduce associated harms. Built into this was partnerships to support people who use methamphetamines in Manitoba. This funding ran from 2020 to 2024. We focused on administrative data knowledge analysis and knowledge use and mobilization. We had key partnerships with First Nations Health and Social Secretariat of Manitoba and the Manitoba Métis Federation. And we used a distinctions approach when working in partnership with these organizations. So the project we saw it as a three-pronged project. We had an administrative data arm, which was focused on the analysis. We had an evidence to action group, which included Manitobans who had used or were using methamphetamines, or their loved ones who were supporting or, um, you know, enmeshed in the person's life who had been using or was using methamphetamines. And then we also had an evaluation arm to really look at how the admin data work and the evidence to action group was working together, knowing that within the administrative data world, there isn't a lot, or a lot of knowledge or protocols around how we work with the public in this space, and so wanting to know what was working well and where we were had room to improve. So the rest of this presentation will look at a couple different facets of how we practice public engagement and how we practice data equity within this project. I'll start with public engagement and say when we first started our evidence to action group, we had the results from the first phase of the study, which a public engagement group had not been involved in. And so at first, we brought those results to this group and really had them engage in interpretation of those results and knowledge mobilization as well. Ultimately, this is not the best way to do public engagement because, they hadn't had any input on what questions were important or the steps preceding that. And so I think it fell a little flat in many ways, because you're bringing something that is just kind of half baked with their input. But this is what we had at the time. And I will say that I know there's a lot of groups that are in this situation that may be thinking about getting community input on their analysis or outputs. And we'll say that is okay, but you have to think about the limitations around that as well. For the next phase of the project, recognizing that it would be best to have their input from the start, we went through a process where the group identified and prioritized the topics. They thought about research design and funding. They were involved in data analysis and interpretation and knowledge mobilization, and then eventually into implementation and evaluation. So a much more thorough engagement at that stage. Um, so thinking about this project through these lenses, um, I want to first start in terms of data equity and data collection. In this project, we started thinking about who gets counted within the data that we have. Primarily, the first documented methamphetamine uses in Manitoba come from the Winnipeg Fire and Paramedic data. And this only includes Winnipeg. And so when we think about, inclusion and exclusion at this point, we're only getting the the urban picture of what is happening. Um, and that is, a limitation that we had to contend with, knowing that we were putting this in the frame of Manitoba, but really only able to look at Winnipeg and excluding that rural dimension from the very start. The other thing we had to think about was that the data documents the most extreme cases. Um, there are many other experiences of methamphetamine use, but particularly within the administrative data, what we see is the most extreme cases where someone is in a crisis state or requiring emergency care. And that is only telling a very small part of this picture. And the final thing here is that first encounter does not mean first time using methamphetamine. And this is, maybe obvious, but it tells us a point in time in someone's life when methamphetamine use may have come to an emergency point. Um, but again, excluding a lot of other experiences that that person may be having. And I have a note here that barriers to accessing services need to be identified by the public. And so this is where that intersection of thinking about data collection, of where the data comes from and who it may or may not exclude, we can do some of the work on our part, but we also need help of the public to say, what are the other barriers to accessing services that they might have experienced to give a better picture. So when we took our first set of results to our public engagement group, one lesson we learned that traditional doesn't always mean trusted. We're a team of researchers, very familiar in bar graphs and dot charts and all that jazz. But we realized very quickly that numbers and graphs can feel very clinical and further move people from the lived experience and the data that they're found in. And so one thing that we did, so this is the first image that we brought to this group, looking at prevalence of mental health disorders in the study population in the 5 years prior to the methamphetamine related contact. And even I remember when we first brought this, the numbers at the top of each bar were added to kind of give that perspective of how many times greater this is, and why that might be significant. But in reality, we just got some very blank stares from our evidence to action group, people who had lived through using methamphetamine or loved ones who were supporting folks who use methamphetamine just said, kind of shrug, like, yes, this affirms their experience, but like, what does it mean? And how can they better inform what these numbers mean? And so our next meeting and meetings after, we really tried to focus on a more visual and narrative story of that data and what this might mean. And so we moved to something like this, where we provided a bit more context. So where that mental health related doctor visit might have come from to show this. Within a visit, a doctor might have provided a diagnosis, had a conversation about treatment, written a prescription, or referred the person for treatment. And this was a better way in to a conversation about, is this something that you have experienced? Were you ever provided a formal diagnosis? Were you ever prescribed something? And much more tangible to talking about people's experience rather than just jumping to an outcome. And so that's one thing that, piece of advice that we've given many times is to think about, if you were engaging, to think about changing the way that you might put your outputs into a more narrative form that feels more tangible and real to people, honestly. Um, that these are their lives. And when you put it into a bar graph, it feels even farther removed from the data that already feels, I think, pretty far removed from them. So within this, we also talked about interpretation. And I will say that Carolyn Shimon was incredibly integral to how we had this conversation with our evidence to action group. We focused on a storytelling model to help bring out either gaps or things that were really important. And so thinking about these questions of what story does the data tell? Does this story resonate with you? What or who might be missing from the story? Might it reinforce stigmatizing attitudes or beliefs? How might lived experience change the story? And together, how can this story help to change care, which was the ultimate goal for many of the members of our group. And so we did that in a number of scenarios, and this is the kind of themes on the right-hand side and some quotes or some summarized nature of this on the left-hand side. And it really helped to shift the kind of interpretation that we might get from, a group of researchers looking around at this to a more, humanized version of this. And I will say that the one quote on the left-hand side that really sticks out um, is the second one down, where someone said a lot of individuals who have used meth had contact with the healthcare system, which would have been an appropriate time to intervene and help. People are not being connected to the right help. So it's not as if people are not coming in contact before an emergency or crisis moment, but they're not getting the right help. And so we started to look at like different ways that this, may become points where the right help could be given. So when we went to phase two of our project, we wanted to really have this group identify research priorities. And so we spent time first talking about like what are the main things that people want to see or people want evidence on to help make changes in the system. And so we used a dotmocracy type of activity after we had narrowed our scope down to show, where the highest priorities were and where we should focus on next. And I will say that this was a rather successful activity for us. It really showed visually where people saw the most value in moving forward. One thing I will say about this process of identifying a new research question is we couldn't offer every idea as something to be prioritized. So one of the priorities of the E2A group was to look at the association between transitioning out of child and family services and methamphetamine use. We had a wonderful youth representative on our group who was very, clear and adamant about their experience in that transition and how, it wasn't just their experience, it was the experience of many, many people in that situation. But we also had to think about child and family services data in Manitoba. And as a lot of people know, about 80% of children in care are First Nations, while making up only 15% of the population. So there is a gross overrepresentation of Indigenous children and families in the CFS data, which means that there are, safeguards put in place to use that data. We know that systemic biases stemming from colonial system has led to this, and that it continues to affect the ways families interact with child and family services, the healthcare system, and other social services. In Manitoba, we have the Health Information Research Governance Committee, who oversees use of the Child and Family Services data, and that is associated with FNISM, the First Nations Health and Social Secretariat of Manitoba. So as much as people were, very interested in this association, given the short timeline that we had to do the second round of analysis, and knowing that, these partnerships would have to be established, not that we weren't already in partnership with Finisum, but it would take many additional steps to do it in that time. And so we could not, conceivably put this as a priority to the group, recognizing that when we think about data equity in this context, it would rightly mean that we would have to do further considerations, which was not in alignment with the timeline that we had. Um, at the end of our project, or not at the end, it was throughout, but at the end, we did more of a fulsome evaluation. But we wanted to look at how reciprocal the collaboration was between the E2A group and the research group. Um, what capacities and for whom is the E2A group enhancing? I think a lot of times we think of, are we giving additional skills to a public group? But also, on the other hand, are we giving additional skills to the researchers who were part of this group or other community members? And where is the information going, and to what extent has it been mobilized to external stakeholders? I'll just go very high level over this. There were some major, successes in our project. I think especially the sense of feeling safe, respected, and treated as equals was really key to our group, and we had established that from the very beginning by creating a, safety charter for our group and going over that at the beginning of every meeting and following that, kind of trying to create as much as we can this non-judgmental space where people felt good about the decisions and people felt good about the discussions. But we had some major challenges when we think about, employing a public engagement strategy within a administrative data research project. The composition of the community or of the E2A committee sometimes felt very lopsided. There were a lot of researchers interested in this, and our public partners were um, variably present within our meetings. And so we would, inevitably have probably between 5 to 7 public partners. But sometimes those people would change meeting to meeting, and the consistency wasn't always there. And that's very understandable due to the life circumstances of those individuals. But it could, and it did, create a space where it did feel lopsided between that. And so by the end, we tried to cut back on how many researchers and sometimes students were coming to these meetings to try to reflect more balance. We thought a lot about the composition of discussion groups. Sometimes we had groups that were, a group was only people with lived experience. And that I think added some safety. And we definitely recognized that anything that was a discussion needed to be in smaller groups. People felt really uncomfortable speaking in a big group format. This, not only because of, just being administrative research projects, but results were slow and progress was slow. And I think compared to the urgency that people with lived experience had in terms of wanting to improve their life circumstances, the research did not follow that timeline. And I think that was really hard to reconcile for people. We wanted to have people with lived experience become more involved. And just based off of time and the complexity of research, we'll admit that was very hard to do, and something that we would want to ensure was set up better if and when we do this in a different study. And again, this need to action this project to create change was very slow, and people were seeing that, and I think frustrated, rightly so. I just want to go back to this data equity of how this is thought about in terms of data mobilization. The sad reality is that the study will end and the public engagement will also end unless you have a unicorn study where you have funding that kind of follows through different projects, or a group that follows through different projects. Your public engagement group or your public engagement itself might end. Um, However, if you've taken, some of these steps, you've already asked what stories are important to the community and how they would like their story to be told. You have a lot of the right information. And this is where it's up to you as a researcher to find ways of having their voices shine through, whether it's in publications, presentations, and other sharing. We recognized this study was coming to an end, and so one of our last activities was having people say, how would you like this story to be told in a presentation if you are not able to be there, or we are not able to pay you to be continued in this project in this way? And that's just, a responsibility that we have to take on the end. But I think the steps before this make this a more kind of comfortable conversation for many people. I'll just say that many lessons were learned in this project. So, adapting public engagement for administrative data studies, there was no one size fits all plan. We contended with COVID-19, moving from intended for, in-person half-day events to virtual, 1.5 to 2 hour events based on people's, time span and what they were dealing with at the time. We contended with the ethics board and their valuing or devaluing of people with lived experience. We worked with the university to compensate people in a timely manner, and that was very challenging. I will say many lessons learned there, which I'm happy to share more about how we navigated that. And then this point about managing expectations of, realizing that the research that we do with administrative data is and can be slow, and it is not about the moment in time, but about the bigger picture, and kind of planning pieces that are farther out than an immediate need. And that can be very challenging to reconcile with a public engagement group. So those are some of the big lessons that we've found. And I will leave this presentation with a couple notes here of just, I think a lot of people in this audience are probably very familiar to this, but asking yourself what parts of your project are actually open to public engagement. If it's a new project, you can really design this from the beginning, thinking about how this fits in when you're submitting a grant application. And I know for certain that Carolyn and her team at CHI have wonderful resources around that. If it's an existing project, you really have to think about where can public engagement actually change your analysis, interpretation, or dissemination of your results. If nothing is open to change, then public engagement isn't the right answer at this time. And that's where you might want to think about other ways that you yourself as a researcher or research team have to think about equity within the data lifecycle, to really reflect that. So, how else can we ensure equity is considered in the data research project, if not public engagement? Um, I think we need to think a lot more about, do you have control over how the data was collected? Do you know how it was collected? What are the biases within those interactions? What do you know about those interactions that precipitated the data? Do people face barriers to receiving a service or being counted? And how can you best reflect that within your analysis if you know that there have been barriers? There are smarter people than me that have thought about bias in terms of how data is curated and linked, and how is it made usable. But I'll just give one example here that we have to think about that when we think about linkage, oftentimes linkage happens based off of key identifiers in the background. And so cases where a name has been changed, maybe a place where records don't become linked. And who does that most affect? Women, people who are transgender and gender diverse, whose names may have changed for different reasons. And so we need to start thinking about that too when we're putting our cohorts together. To what effect or to what extent does that affect the research that we're going to do? And then this last point of have you trained your team to consider elements of social oppression and inequities? This is not a one person on the team thinks about these things. It's a everyone needs to be thinking about these things from their own vantage point or place of expertise. I am not by far an expert in data curation or linkage, but the folks on our team who are can be pointing out those places where bias or just honestly technical processes may exclude different people or different groups of people. Um, the key takeaways for me is that public engagement alone is not sufficient for considering or embedding equity in a data research project or any research project. The public is not your only answer to equity and inclusion. And I think sometimes if we think about, how can this project better reflect equity, the public or public engagement as seen as this kind of shortcut or answer. But in reality, there's multiple opportunities along the project lifecycle and the data lifecycle for public engagement and data equity. Some of this work, it is required that you engage with the public and do that work of understanding the social situations that precipitated the data or the world in which you're working. But sometimes it's really up to you to understand the data lifecycle, the data process, where and how inclusion or exclusion can happen along that life cycle, and do the work within that technical environment because the public is not going to be the answer to that. Um, and that is the end of the presentation. I do have resources that are helpful in terms of researchers thinking about data equity and what that looks like. And I know Maxa will be sharing those, whether in the chat or after the presentation. But I'm very happy to answer any questions. And yeah, thank you for having me.
Thank you, Amy. I really appreciate the humility that you showed, and how you walked us through the successes and challenges of patient engagement in your project. Um, I will be sharing the slides via email um, at, at the end once the recording is up on YouTube. We are open to questions in the Q&A box, which is the box with the question mark in the center on the bottom. But while we wait for some questions, I want to know, curious about how you recruited your patient partners in an equitable way.
Good question. Yeah. So, Carolyn and her team at CHI were instrumental in helping us recruit members for our E2A group who are not, professionals in this space, and so people with lived and living experience. And some of the questions were we posed to people were very practical of just like, when can you join these meetings? How long could you actually be in attendance for these meetings, etc. And there were discrepancies between our research team and the people with the lived experience in terms of when the meetings were most convenient and how people could actually attend. And we had to, um, it was not a simple solution, honestly. We sometimes had meetings in like the afternoon and sometimes had meetings in the evening at a location that wasn't on campus. And so we asked some of those questions in terms of recruitment, and I think um, it was ultimately a lot of like snowballing of we found, someone who might be interested, and they would say, "Oh, we have this other person who would be a great participant in this." And at the time we didn't like ask any questions about like diversity explicitly, but more so found ourselves within that sphere of like interest and um, availability, I will say. But at the end of the day, I think we did have a diverse group of people with lived experience, despite those things not happening at the time.
Thank you. Mary would like to know if you could speak about your process for establishing your research to action patient engagement group. How did you identify people and bring them onto the team? How long did it take to establish the group?
Yeah. So I just answered a little bit about the recruitment, and I don't know, Carolyn, if you wanted to say anything more about that. But
Um, Thinking back,
yeah.
yeah, I think you did a great job covering it, Amy. I was just gonna add the being flexible around how people come. We started during COVID, and we had some folks who did not have access to technology, so we were able to really rely on community health centers such as Nine Circles, who really helped us in setting up. Sometimes we would work with healthcare workers there who could help find a room and set up a computer for some of our partners to come and join when we were forced to go virtual. And then, yeah, and just all that, the flexibility of how you join. Also, getting to know each of the people on how they best communicate. So we had some folks who shared cell phones, and we'd have to find ways to send information via text message. And also, I think. Amy, when you were talking about the idea that the snowballing, that sometimes folks would invite friends and so on. So being open to the idea that someone might join the group and not have the previous background of what we did in the last session, and just being kind of nimble on your feet to be able to kind of give a little bit of a brief what had happened previously, and have activities that folks could still contribute to, even if they weren't actively involved in previous sessions.
Yeah. And I'll say too, like at the be very beginning, we did, recognize that this was going to be a different way of working for researchers or professionals who maybe work with the community. And so prior to starting the E2A group, we held a couple sessions on cultural safety and trauma-informed care to kind of get people at a place to recognize that like this isn't going to be just meetings about like sharing results and you providing your kind of professional expertise, which I think was important to this. And then when we started the group, we held a couple, visioning and safety exercises to get that perspective of like what was important to all the members of this group that would create a safe space, whether it be virtual and online. And I think for any project, I would definitely do that again. Even though like it takes maybe a bit longer to get into the research. I think it was very instrumental to having a group where people felt comfortable to say what they needed to say. And we did go back to that over and over again. And yeah, I think like it probably took us like a year to really gel um, in any real way. And I think like it was hard with the COVID circumstances as well, but um, we kept going.
Yeah. And that was a perfect answer to the next question, which was what specific training do you recommend for the team or individuals? And you mentioned some equity training, some trauma-informed training. Um, the next question is, let me just put it up so that people can see it. How do you navigate patient partner representation for projects or research with severe diseases or rare situations?
I think I think what Carolyn said about flexibility um, is really key to this.
Hmm.
We knew that there would be like specific challenges when thinking about people who had lived experience in terms of methamphetamine use. But we didn't see it as like a deterrent to move forward and have people involved. Um, and I do think that that like made certain people very uncomfortable. Like there's those of us who love to follow an agenda and love to do things in the way that we've been trained to do for most of our
Hmm.
lives. But when you're working with groups that do have these different needs, the agenda, sometimes flies out the window. And
Hmm.
having that ability to be like, okay, that happened. It's okay. We can um, pick up where we left off, or maybe it was a detour that showed a gap where we might need to spend a bit more time.
Hmm.
Um, I don't think we handled that perfectly, but it was a reality. So, um, it's just one of those things. And I think this is a conversation to have with your group of like, you might have put into a grant, we'll meet 3 or 4 times a year for this amount of time, but does that actually work for people? Like for people who might have like chronic pain or very like dealing with that, like it's probably not going to work to meet for half a day. Um, so you're gonna have to negotiate that with people and kind of work your budget around that too.
So meeting people where they're at, balancing between expectations of the grant and the project and the realities of people with lived experience.
And I think, Amy, what you're mentioning around the flexibility piece, like a key part of trauma-informed engagement is allowing for choice always that folks with lived and living experience choose how they want to engage and how they prefer to engage and that it can change, right? It can change at any moment of time and that having that like the research team was so amazing at being able to be flexible and to change based on folks where they preferred and how they wanted to be met. And it's such a crucial part of the
Um, Jody is asking, were there any themes from the lived experience consultations or informative for future research on unanticipated areas or topics?
Yes. So I think beyond the one topic that I talked about that we couldn't answer as part of this project that, I know we are pursuing different funding to do that, but as you know, funding can be fickle. Uh, so there was that. And there was also work around people's connection with community health centers and how community health centers um, was affecting their quality of care. And that's something that we, just touched the surface on in terms of seeing, how people were connected to different community health organizations here in Winnipeg. But there's so much more to think about there as like, can these places be, better at connecting people to the right care at the right time? Just knowing what we know about the mental health associations and other outcomes that, you know, one thing that we heard and I, truly believe is that people said it was easier to access methamphetamines than it was to access mental health care. And that's a like pretty hard reality to hear, but I think very important in terms of knowing, okay, what are those actual barriers and can we reduce them where people are at actually?
Um, we have a question that is curious about the human resources that supported engagement in the research. Did you have staff who were only working on the engagement work of the project, or was everyone on the team responsible for some of the components? In retrospect, would you include any other positions or roles?
Yeah, so we had, I mean, thankfully, we had a great team, which included Carolyn and at the time Ogai from CHI, and they were really instrumental in kind of like keeping that patient partner relationship going. I will say that if we did it again, we should have more people from the research team involved in those like more constant connections. Um, and that was, I think, an oversight on the research team's part. We also had for this project, thankfully, too, a wonderful project manager, and who she also was highly involved in doing this work. Uh, and without her, like, just the things like paying people and organizing rooms and food and things like that could not have happened. So we're grateful that that was put into our budget as well. And can you say the second part of the sentence? Because I feel like I,
Curious about the human resources that support engagement in the research. Okay. Did you have any staff who were only working on the engagement work of the project, or was everyone in the team responsible? You answered that. And
yeah.
in retrospect, would you include any other positions or roles?
Yes. So if we were to do this again, I think having a specific patient or public role within the research team would be important. And I'm blanking on there is a there is a position now, I believe. I don't know if it existed at the time within the university structure to recognize patient partner expertise. And Carolyn, if you have it at the top of your mind, let me know. But
Is
I
it the
think,
community researcher role?
yes,
Yeah.
yeah. And I think that that would be like a super um, critical addition to the research team that we just didn't have as an option at the time.
Patient engagement seems to be the gold standard in research in healthcare. Do you have any advice on how to avoid tokenism? And where do you see patient engagement heading or shifting how research is conducted?
I think that there is a lot of tokenism. Like, when we think of these groups, it's often the same people participating time after time. We see a lot of like, once you have one person who's involved, they can become the like voice of many people, even though that's not the intention at the beginning. Um, uh, this is me being biased, but I will say that I think part of patient engagement is the gold standard, but there are many other things that you can be doing to recognize equity within your project and within your data. And I think that that is in some ways where we're going, is that, we can't, in every project, there isn't always an option to do patient engagement, but there is options that we can do to ensure equity is considered and practiced. So some of the things that we're, trying to do on the technical end of things is ensure that, well, can we somehow build community voice into the metadata so that there's a, interpretation at that level of, this is the data that we have, these are the barriers to accessing it on a very broad level. And that's not like you can't do that for every project. And so it's something that, if we can do it, once or every few years to get that perspective, it bakes in that public and patient perspective into the data. And I hope that that's where we kind of go with this is like, yes, patient and public engagement, key. There are other ways to incorporate patient and public voices without always doing, a group or a consultation or something like that. And we have to find those other ways to incorporate it into the technical data spaces that we have.
There are so many more questions in the chat. Sometimes it's good to leave them wanting more, and I want to be respectful of everybody's time. It is 1 o'clock. So I would like to thank you, Amy, for presenting your experience in with public engagement in health equity. Um, it was so valuable. And as you could see by the questions, there's so much curiosity and learning that we all have to do. Um, you will receive a follow-up email with further information on how to access the slides and recordings. We also welcome your feedback for the session with a poll that you will be asked to complete once you close the webinar. And we would like to invite you to join us for April's PELL with Maria Branoski, Patient Engagement in Nutrition Research, partnering with parents and caregivers of children born with trisomy 21 living in Manitoba. Maria will share how her experience consulting with parent and caregiver research partners informed aspects of her PhD research project. Maria will highlight her positionality as an insider outsider research who shares her lived experience with her study population. Thank you to everyone who has joined, and I hope you walk away with some more tips and tricks to include patient engagement in your research.